My name is Michael Reade. I'm an anaesthetist and an intensive care physician in the Australian Defence Force and at the Royal Brisbane Hospital here in Brisbane, Australia. And being a defence intensivist, I have a particular interest in burns, as we do at the Royal Brisbane Hospital. We're the burns centre for all of Queensland in Australia. And we see in particular a lot of burns patients transferred to us who have long pre-hospital times. Queensland is one of the largest Australian states, and it's not uncommon for us to see patients 24 hours after their burn. So we're quite experienced in the critical care aspects of burns management, both remotely and in managing patients who've had prolonged resuscitation prior to getting to us in hospital. And that's what I'm going to talk about here in this lecture. I do have some conflicts of interest. I'm going to touch on sedation during this talk, and I've been the investigator in a number of sedation trials primarily related to dexmedetomidine. I'm not going to touch on dexmedetomidine though in this lecture. When we talk about burns, you would think that we've been doing this for some time, and we should have some pretty well established guidelines, and that really we should have fairly uniform practice worldwide. And indeed, if you were to Google guidelines for burn care, you would find this document, a consensus set of guidelines from 2016 that would, at a superficial reading at least, lead you to believe that that's true. However, if you were to look in more detail at this guideline, you would realise that it really focuses on the surgical management of burns patients, and it does that extremely well and in a lot of detail. It talks about early debridement and the different types of burns dressings to be used and so on, but it really provides very little advice for critical care physicians. And by way of example, I'll show you some guidance it gives here on the type of fluid resuscitation that patients should receive. It says that they should receive that promptly, and that it should be based on tailored to patient parameters. And it should be based on their physiological needs. What's more, it should be a salt-containing fluid, and that some experts consider that that should be a balanced salt solution. What's more, nutrition is important, and that the nutrition should be calculated using a formula, but it doesn't necessarily give a specific guidance on what formula should be used. So these really aren't critical care guidelines at all. And therefore, it's not too surprising that there's a fair amount of heterogeneity in the management of burns, or at least that's what we thought would be the case, given our understanding of these patients who we have transferred into us in our burn centre in Queensland. But we thought it would be wise, before doing anything about this, to accurately quantify whether that was true, at least in the Australian context. And so we set about doing that in a survey of critical care burns practice in Australia and New Zealand. This is a picture of Anthony Holly, who's one of the burns intensivists here at the Royal Brisbane, and this was essentially his project, which we did in collaboration, that I'm going to present in the first half of this talk. So we sent out a survey to all Australian intensive care physicians in the 8 burns centres in Australia and New Zealand, and we had a response rate of 65%. And we set it around a scenario of a 58-year-old male with 75% burns, and at least at the start we said without inhalational injury. And we asked questions in 4 domains around resuscitation, management of the airway, burn-specific therapies, and then some specific supportive intensive care measures. And at the start, we were pleased to find that by and large there was some agreement about fluid resuscitation. Most Australian intensivists would use, and New Zealand intensivists would use, the modified Parkland formula. Most would use Hartmann's, and the ones that didn't, by and large, would use Plasmolite. And most targeted a urine output of 1/4 to 1/2 ml per kilo per hour, some under, some over. So that was fairly homogenous. We were encouraged, but the consensus ended there. If the patient had an inhalational injury, 50% of people said that they would modify the amount of fluid that they would give, and the other 50% said they wouldn't. Of the ones who said that they would, about a third said that they would decrease it, and the rest said that they would increase it by a varying degree. We asked whether colloids were indicated in the management of burns, and about a third said yes, they were. About a quarter said they definitely weren't, and a bit over a third said, well, they weren't really sure. At least there was general agreement now in Australia, largely because albumin is free, that if they were going to use a colloid, then that colloid of choice would be 4% albumin. Then we changed the scenario a little and said, well, first of all, if there was nothing to suggest an inhalational injury, would you perform a bronchoscopy routinely? And 50% of people said they would, 50% said they wouldn't. But if there was an inhalational injury, would you use nebulized heparin, for example? And about a third said they would, and 2/3 said they wouldn't. And then there was a spectrum of opinion about whether people would use various other inhaled therapies, including hypertonic saline, N-acetylcysteine, or a combination of those types of therapies. There was a broad acceptance that tracheostomy was going to be indicated in this sort of a patient, but the timing of that tracheostomy was very variable. It averaged out at about 2 weeks, but in about 25% of cases, it was going to be done beyond 2 weeks. The majority were happy to do it percutaneously, but about 20% preferred to do an open procedure in a burnt patient. In terms of nutritional goals, interestingly, contrary to those guidelines I showed you before, the majority of people wouldn't use a formula, but said that they would use a fixed value. About a third said they would use fortified feeds. A very high proportion said they would measure trace elements in the blood, which interestingly we don't do. We all know about burn-associated ulcers, but not everyone would use stress ulcer prophylaxis. And there was about a 2/3, 1/3 split about the use of unfractionated heparin and low molecular weight heparin. We know these patients commonly get febrile and need cooling, but there was a wide spectrum of opinion about how to actively cool such a patient. Most people, 50%, said that they would target the conventional hemoglobin concentration of 70 to 80 that we use in all of our critical care patients. But of course, that meant the other 50% targeted a higher concentration than that in burns, despite the fact that there's really no evidence to support that. Most targeted a higher platelet count than we generally target in our critically ill patients, again, with very little evidence to support that. And the perioperative INR target, we know these patients bleed when they go for their debridements, also not terribly evidence-based, and quite a spectrum. We tend to avoid antibiotics in burns patients, but there was quite a heterogeneity of opinion about when and if antibiotics would be prescribed prophylactically. And then there were some burn-specific therapies that really varied around the two countries as well. About a third of units using burns baths, about a third using the anabolic steroid oxandrolone sometimes, and there is some evidence for that. And there is actually quite good evidence for using a beta blocker, at least later on in the critical care course, but not everyone does that. So in summary, by and large, we agree on the type of fluid. We don't agree on just about everything else. One thing that we did find very interesting was that there were clusters of answers. In other words, people tended to follow the leader in their institution. And so we saw that as more a glimmer of hope than anything else, that people were willing to take advice if indeed there was some evidence-based advice to give them. And by and large, our findings are similar to those of other international practice surveys around the world. And I'm not going to go through these in detail, but others have done similar things around the world in Canada, in the United States, again from the United States and in Europe, seeing a heterogeneity of approaches to everything from fluid management to how to secure endotracheal tubes and so on. Why is this? Why can't we agree? Well, this systematic review looked at the quality of the evidence in burns and found actually very little evidence to guide our practice. Of 46 randomized controlled trials and cohort studies with controls, most concerned just fluid resuscitation. So not surprisingly, we're sort of on the same page with fluid resuscitation. And most of the rest concerned analgesia, which we haven't even really touched on. So really everything else we've talked about has very little or no randomized controlled trial evidence to guide our practice. And then, of course, all of those are surveys of what people say they do. And really, there have been almost no audits of what people actually do. This was one of the only studies that I could find, and it's a nutrition practice in burns, finding actually a relatively high level of compliance in green with most of the guidelines. But nutrition is an important but a relatively small area of burns practice. So if we're going to improve things, what should we do? Well, we think we need to start a registry, and we need to quantify this practice. Now, we have a burns registry in Australia and New Zealand, but again, it's a surgically focused burns registry, as you might be able to tell by looking at the titles of some of the papers that have been published based on it on the right-hand side there. We have a critical care registry, our ANZICS registry, that has a lot more detail about critical care interventions, but it doesn't specifically target much information around burns. So we think we need to essentially put these two things together. We're going to do that in a very sensible way. We're going to look at a factor analysis of what information to collect in such a registry. And a factor analysis essentially involves looking at a large number of data points, but then looking at how those data points cluster together and eliminating those that are essentially duplicating information so that we collect a minimum data set that gives us the most informative information. And we think that that will tell us when it's up and running, not only which treatments are evidence-based but need better translation into practice, but also which questions need better trial evidence before they can then be written into guidelines and translated. We think that the sort of questions that might lend themselves to randomized controlled trials are along the lines of the things that we've talked about up until now. Of course, if we're going to do randomized controlled trials in burns, we need to take a few things into account. And that is that there's such heterogeneity in burns patients that a randomized controlled trial can really be quite challenging, as it is in all trauma. And so what we really need to do is come up with a trial design that separates signal from noise. And in a way, it's a bit like looking at a mountain through clouds. To see that signal through the noise, you need something like a very big mountain, in other words, a very big effect size. You need to watch for a very long time, that is to say a long sample size, or you need to look for surrogate outcomes, like a shadow over the mountain, or indeed things like biomarkers and so on. And what's more, you need to have a sensible approach to endpoints. And traditionally, we look for 28-day mortality or maybe even 90-day mortality in critical care. But most burns patients, if they survive the first day or so, tend not to die. And so really we need to look at more sensible endpoints in our randomized controlled trials that are relevant to the patient's needs. And in particular, in burns, looking at long-term functional outcome, we think will be a very effective outcome to measure. So that's our plan. We've started with our survey, but this is a program of research that we anticipate will progress over many years, and I look forward to telling you about it in future conferences.